Obstructive sleep apnea is an anatomical disorder and is driven by abnormalities in the upper airway that increase the collapsibility and reduce the airway function. Enlargement of soft tissue within and around the airway, including the tongue, the soft palate, tonsils, and fat deposits, can cause a narrowing of the airway. The epiglottis, which prevents food from entering the airway, normally remains open during breathing, but it can collapse during sleep, and it's also a frequent source of obstruction and snoring. Many groups have attempted to correlate the anatomical source of the obstruction with the obstructive sleep apnea severity, with limited success. However, the nature of the obstruction may have a significant implication for the treatment strategy, and a comprehensive assessment of the underlying pathophysiology of the obstructive sleep apnea may facilitate an individualized approach to the treatment. There's two main types of sleep apnea, obstructive and central, with obstructive being more common. In obstructive sleep apnea, the upper airway intermittently becomes fully or partially blocked during sleep. In central sleep apnea, the respiratory control center in the brain doesn't provide sufficient stimulation to maintain regular breathing during sleep. In some cases referred to as a complex sleep apnea, elements of both obstructive and central sleep apnea can occur simultaneously. In obstructive sleep apnea, anatomical abnormalities and sleep-associated neuromuscular dysfunction coalesce to result in repeated airway blockages. The temporary pause in the airflow results in frequent arousal as the brain reacts to reinitiate breathing. Obstructive sleep apnea is a state-dependent condition, and it occurs only during periods of sleep, primarily due to the positioning. When in the spine position on the back, gravity promotes collapsibility of the airway and it blocks airflow. Obstructive sleep apnea is very common among adults. A community-based study of over 5,800 adults over 40 years of age found 46% of the subjects had some degree of obstructive sleep apnea, suggesting the condition is vastly underdiagnosed. The natural breathing reflex is regulated by the autonomic nervous system, and it responds automatically to changes in blood carbon dioxide levels. In central sleep apnea, however, the brain doesn't adequately respond to the excitatory signals that trigger respiration, including carbon dioxide levels, and the regulation of breathing is disrupted. Disordered breathing is thought to only occur during sleep because sleep diminishes the brain's response to excitatory signals. Central sleep apnea occurs primarily in infants, both preterm and term, in the first weeks of life. Adults abruptly transitioning to high altitudes, and to patients with heart failure, but it can also be idiopathic in nature, with no clear cause. Compared with obstructive sleep apnea, central sleep apnea is much less common, occurring in less than 1% of adults. Mixed sleep apnea, also referred to as complex sleep apnea, involves both obstructive and central components. Approximately 5.5% of the people with sleep-disordered breathing, the broad category that includes apneas as well as the less severe hyponias, or shallow and slow breathing, have complex sleep apnea. In many cases, central apnea is revealed during the treatment of obstructive aspects of sleep apnea. Sleep apnea is associated with several serious health conditions, and at least some of these associations appear to be causal to some degree. This means sleep apnea may directly contribute to the development of the associated health condition, although this might not always be clearly delineated in each patient. Historically, there's been conflicting evidence regarding an association between sleep apnea and blood pressure. For example, in a cross-sectional analysis of over 6,000 participants in the Sleep Heart Health Study, participants with severe sleep apnea were 37% more likely to experience hypertension than those without evidence of a sleep apnea. However, in a 5-year follow-up of a subset of these patients without hypertension at the start of the study, there was no association between the development of hypertension and sleep apnea, after accounting for body mass index, suggesting this association may instead be caused by the obesity. A direct association between obstructive sleep apnea and hypertension is most strongly supported by studies that demonstrate that the treatment of obstructive sleep apnea also lowers blood pressure. Meta-analyses of clinical trials have found that a treatment of obstructive sleep apnea using a CPAP results in a reduction in systolic blood pressure as well as a reduction in diastolic blood pressure. These effects are small, but they may have significant implications for heart health, as a small reduction in blood pressure has previously been shown to decrease the risk for cardiovascular disease, including stroke and heart failure. The association between sleep apnea and blood pressure is likely bidirectional and driven by a number of factors, including overactivation of the sympathetic nervous system, oxidative stress resulting from intermittent hypoxia or periods of low oxygen, and the disruption of hormone levels. Sleep apnea, and particularly obstructive sleep apnea, is highly prevalent in patients with cardiovascular disease, including heart failure, stroke, atrial fibrillation, and end-stage renal disease. Intermittent hypoxia is thought to cause endothelial damage, inflammation, and metabolic dysfunction, which contribute to an increased risk for cardiovascular disease. There's been some conflicting evidence, however, on whether the treatment of sleep apnea improves cardiovascular outcomes. In a clinical trial of 2,717 adults with moderate to severe obstructive sleep apnea and cardiovascular disease, management with a CPAP did not reduce the frequency of cardiovascular disease events. Similar results were seen in a smaller clinical trial involving 244 patients with obstructive sleep apnea and coronary artery disease. However, when the results were adjusted for the adherence to treatment, i.e. comparing those who used the CPAP for at least 4 hours per night against those who didn't, the CPAP reduced the cardiovascular disease risk by 71%. A meta-analysis of 8 studies on obstructive sleep apnea found CPAP reduced the risk of atrial fibrillation by 42%, providing further support that CPAP, when used properly, reduced cardiovascular disease risk in patients with obstructive sleep apnea. The cardiovascular benefits of CPAP and other sleep apnea treatments in patients with central sleep apnea and heart failure, however, is less clear. Obesity is a well-established risk factor for obstructive sleep apnea, and the relationship between obesity and sleep apnea is likely bidirectional. Disordered sleep has been found to increase the risk of weight gain through physiological and hormonal changes, as well as behavioral changes. Obstructive sleep apnea is also associated with type 2 diabetes. Approximately 54% to 75% of the patients with type 2 diabetes have obstructive sleep apnea, and type 2 diabetic patients are 48% more likely to have obstructive sleep apnea than individuals without diabetes. Additionally, type 2 diabetic patients with obstructive sleep apnea are over 3 times more likely to develop diabetes-related complications than those without. This relationship likely reflects the complicated interplay among metabolic changes, weight gain, and hypertension. Intermittent hypoxia can also cause insulin resistance. There's been conflicting results regarding the ability of the CPAP treatment to improve glycemic control in patients with type 2 diabetes. However, preliminary results suggest the treatment of type 2 diabetics with pharynxia, a sodium glucose cotransporter inhibitor, a class of medicine that lowers high blood sugar levels, can improve the sleep and decrease the oxygen desaturation events in the patients with type 2 diabetes and sleep-disordered breathing, suggesting the treatment of comorbid type 2 diabetes can improve sleep apnea symptoms. Obesity hypoventilation syndrome is a condition characterized by a BMI of greater than 30 kg per meter squared, elevated daytime carbon dioxide levels, and sleep-disordered breathing. While this disorder is often closely associated with the presence of sleep apnea, and particularly obstructive sleep apnea, it's a separate clinical entity. Studies suggest obstructive sleep apnea can be associated with the development of cognitive deficits in areas including attention, executive function, visuospatial reasoning, and both short and long-term memory. This might be driven by a number of factors, including chronic sleep deprivation and hypertension. An estimated 27% of individuals with mild cognitive impairment have obstructive sleep apnea, and this can accelerate the progression of the mild cognitive impairment to Alzheimer's disease in some individuals. Results from a small clinical trial involving 54 individuals with mild cognitive impairment and obstructive sleep apnea suggest proper adherence to a CPAP treatment is associated with a small but significant improvement in memory, attention, and everyday function. Obstructive sleep apnea has also been linked to several affective disorders, including anxiety and depression. For more on sleep apnea, herbs, supplements, or natural treatment plans, check out my website.